On this episode of the ASC Podcast with John Goehle, we review the revised conditions for coverage related to the vaccine mandate and the accompanying instructions to surveyors as to how to assess compliance. And in our focus segment, we visit with the AHS staff during their fall 2021 retreat and discuss the current challenges in the industry and how ASCs can prepare. Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. This episode is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers and ambulatory healthcare strategies, the nation's leading regulatory compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 147 of the ASC Podcast with John Goehle for December 30th, 2021, recording from our studios in Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies. He is recognized as one of the nation's leading experts in the ambulatory surgery industry. John is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues.
And here we are, only 2 days after we recorded the last episode, and actually a day after we did a nice quarterly update last night. So we're recording on Thursday and Wednesday night. All of our patron members, the people that are members of our patron program, which is also known as ASC Central, were able to get together and we did a slide presentation on a number of different issues. I think we were talking about the vaccine mandate, which is always a great topic. We were talking a little bit about the No Surprise Billing Act, and we also talked about the upcoming changes to the ASC Quality Reporting Program from Medicare. So had a great interaction. I think we had probably about 15 people at one point, so it was a nice interaction. We have over 100 members right now, Sue, in our patron program, so we're very grateful for all of the support that they have for us and the interactions that we get during our weekly updates and our quarterly presentations. So
and of course, most of the time we have Lori Rodricks and Ann Geyer has been joining us. So got 3 surveyors and lots of knowledge there.
Yeah,
so
it's a great opportunity. We enjoy those, all of those events. It's great to get together and listen to our listeners and get ideas from them as to, upcoming topics. And we're going to talk about that in our third segment. We got a lot going on in the future here. I hope everybody is having a great holiday. It's coming to the end of 2021, another year that I think we're all kind of grateful to see disappear. Maybe not as much as 2020 was, but I would hope that 2022 will be better. We'll probably get one more episode in before the end of the year here. We have to talk about surprise billing, and we have a interview that we did on that topic. So hopefully you and I will be able to do that on New Year's Eve tomorrow.
I was going to say, we've got a whole, day or two.
I know. We're going to have to work on that. Before the end of the year. And we are trying to get caught up on our material. We are about 6 episodes behind right now in material. So we pretty much wanted to dedicate the entire news section here on a very important quality and safety oversight memo that came out this week, which we think needs to be addressed. And of course, it's about the vaccine mandate.
So on December 28th, CMS issued a quality, safety, and oversight memo to the states and the accrediting organizations entitled Guidance for the Interim Final Rule, Medicare and Medicaid Programs, Omnibus COVID-19 Healthcare Staff Vaccination, or QSO 2207 ALL, which adds a Section C to the conditions for coverage in Section 416.51 infection control. So we've added a link to this in the show notes for the episode. And it's not that common to have a new condition for coverage. Right? It's a pretty serious thing.
The way they addressed it was unusual, which, of course, gives us serious issues with regard to surveys. So it shows how serious they're taking the vaccine mandate. And we're well aware that there are, legal challenges to this also. We'll talk about that in a second. But with the publication of this QSO-22-07, CMS has adjusted the compliance dates for this regulation, in other words, the vaccine mandate. So there are now two new compliance dates. The Phase 1 compliance date for the mandate is now January 27th, 2022, which is 30 days after the release of the memo this week. And it requires the staff to have the first vaccine in a 2-dose regime. This is also the compliance date for requesting a federally recognized exemption.
And Phase 2 compliance date for the mandate is February 28th, 2022, or 60 days after the release of the memo. And Phase 2 involves covered staff receiving the second dose of a multi-dose vaccine, or the single dose of a single-dose vaccine, or having received a federally recognized exemption.
So I think a couple differences between Phase 1 and Phase 2. If you're going to get a 2-vaccine regime, you should have the first one by January 27th, and then the second by February 28th. If you're only going to have the one vaccine, you have to have it by February 28th. Now, we should also mention that if you are going to get a federally recognized exemption, you have to put the application in by January 27th, and your employer has to act on it by February 28th. So in our episode last week, which we dated and timed, I believe.
Good thing.
Right. We indicated
hour.
Right. We indicated 10 states where the regulation is not going to be in place. And so with the issuance of the QSO, the total number of states that are currently where they're not going to enforce the vaccine mandate is up to 25. Sue, why don't you list the 25?
Okay. So I'm going to list these, and also keep in mind, though, that this could change at any time, I think January 7th, which we'll talk about further on. So there's Alabama, Alaska, Arizona, Arkansas, Georgia, Idaho, Indiana, Iowa, Kansas, Kentucky, Louisiana, Mississippi, Missouri, Montana, Nebraska, New Hampshire, North Dakota, Ohio, Oklahoma, South Carolina, South Dakota, Texas, Utah, West Virginia, and Wyoming.
I kind of imagine everybody was kind of listening to that, just like we did as a kid when we were waiting for our snow to be. Or maybe that's only something.
Say my
is my state going to be on the list?
Don't get too comfortable because we're changing all the time.
So surveyors in these states have been instructed to not undertake any efforts to implement or enforce the regulation.
And on December 22nd, the Supreme Court of the United States indicated that it will hold a special session on January 7th, 2022, to hear oral argument in cases brought by a number of states requesting that the OSHA and CMS vaccine mandates be stayed. Note that this is a highly unusual move on behalf of the Supreme Court and an indication of how seriously they're looking into the mandates.
So on or after the oral arguments on January 7th, the court will address only whether the mandate should be preliminarily enjoined pending litigation and the decision in the lower courts. It should be noted that the standard that the court will apply for granting preliminary relief will involve determining whether the states asking for the stay can demonstrate that they are likely to win the case based on the merits of the case.
And the January 7th argument is likely to result in a number of opinions from the court. So whatever happens, it should be noted that the court's decision will not be a final decision about these mandates. And just a reminder, because of the deadlines, it's really important to note that even if you are in a state where the mandate cannot be enforced, you need to be prepared to act quickly if the court reverses direction on this.
Yeah, and another point to make is that you have to weigh both the federal mandates and the state mandates to determine which have stricter requirements. I'll give you an example. For example, in New York, the mandate in New York doesn't allow for a religious exemption. However, the federal mandate does. Therefore, the federal requirements will stand with the exception that you cannot use a religious exemption in New York since that is stricter.
Okay, so now we're going to go right on to the actual condition for coverage and the interpretations.
And please bear with us. This is indeed one of the longest standards in the conditions for coverage ever written, which is very unusual. And I think it took me about 4 hours to go through this to parse out what we have. And I apologize if I've summarized it too much, but we are giving you a link to the entire document so that you can read through it. And unfortunately, I do recommend that you do read the whole thing.
Yeah. So the new standard reads as follows. Standard COVID-19 vaccination of staff. The ASC must develop and implement policies and procedures to ensure that all staff are fully vaccinated for COVID-19. For purposes of this section, staff are considered fully vaccinated if it has been 2 weeks or more since they completed a primary vaccination series for COVID-19. The completion of a primary vaccination series for COVID-19 is defined here as the administration of a single-dose vaccine or the administration of all the required doses of a multi-dose vaccine.
And moving on to item number 1 under the standard, regardless of clinical responsibility or patient contact, the policies and procedures must apply to the following center staff who provide any care, treatment, or other services for the center and or its patients. Number 1, center employees. Number 2, licensed practitioners. Number 3, students, trainees, and volunteers. And 4, individuals who provide care, treatment, or other services for the center and or its patients under contract or by other arrangement.
And I think that's important, regardless of clinical responsibility or patient contact. So, that's an important note.
Yeah.
And number 2, the policies and procedures of this section do not apply to the following center staff. Number 1, staff who exclusively provide telehealth or telemedicine services outside of the center setting and who do not have any direct contact with patients and other staff, specified in paragraph C1 of this section. And 2, staff who provide support services for the center that are performed exclusively outside the center setting and who do not have any direct contact with patients and other staff, specified in an upcoming paragraph of this section.
And the policies and procedures must include, at a minimum, the following components. So this addresses the what changes you're going to need to make to your policies and procedures. And listen to it closely because the surveyors are required as part of their instructions to read through the policies.
Because it's important that everybody's vaccinated, but if everybody's vaccinated but you don't have any policies in place,
that's exactly right. That's exactly
going
right.
to be a problem.
So the policies must include at a minimum the following components. Number 1, a process for ensuring all staff identified in paragraph C1 of this section, except for those staff who have pending requests for or who have been granted exemptions to the vaccination requirements of this section, or those staff for whom COVID-19 vaccination must be temporarily delayed as recommended by the CDC due to clinical precautions and considerations, have received at a minimum a single-dose COVID-19 vaccine or the first dose of the primary vaccination series for a multi-dose COVID-19 vaccine prior to staff providing any care, treatment, or other services for the center and or its patients.
And number 2, a process for ensuring that all staff specified in paragraph C1 of this section are fully vaccinated, except for those staff who have been granted exceptions to the vaccination requirements of the section, or those staff for whom COVID-19 vaccination must be temporarily delayed as recommended by the CDC due to clinical precautions and considerations.
Number 3, a process for ensuring the implementation of additional precautions intended to mitigate the transmission and spread of COVID-19 for all staff who are not fully vaccinated for COVID-19.
Number 4, a process for tracking and securely documenting the COVID-19 vaccination status of all staff specified in paragraph C1 of this section.
Number 5, a process for tracking and securely documenting the COVID-19 vaccination status of any staff who have obtained any booster doses as recommended by the CDC.
And 6, a process by which staff may request an exemption from the staff COVID-19 vaccination requirements based on an applicable federal law.
Number 7, a process for tracking and securely documenting information provided by those staff who have requested and for whom the center has granted an exemption from the staff COVID-19 vaccination requirements.
And number 8, and again, this has gotten so long, but remember, these are all of the policies and processes you must have in place.
For the surveyors to review when they come in,
yep.
Right.
So number 8, a process for ensuring that all documentation which confirms recognized clinical contraindications to COVID-19 vaccines and which supports staff requests for medical exemptions from vaccination has been signed and dated by a licensed practitioner who is not the individual requesting the exemption and who is acting within their respective scope of practice as defined by and in accordance with all applicable state and local laws, and for further ensuring that such documentation contains All information specifying which of the authorized or licensed COVID-19 vaccines are clinically contraindicated for the staff member to receive and recognize clinical reasons for the contraindications. And B, a statement by the authenticating provider recommending that the staff member be exempted from the center's COVID-19 vaccination requirements based on the recognized clinical contraindications.
Continuing, item number 9, a process for ensuring the tracking and secure documentation of the vaccination status of staff for whom COVID-19 vaccination must be temporarily delayed as recommended by the CDC due to clinical precautions and considerations, including, but not limited to, individuals with acute illness secondary to COVID-19 and individuals who receive monoclonal antibodies or convalescent plasma for COVID-19 treatment, and 10, contingency plans for staff who are not fully vaccinated for COVID-19. And I think that last one is very important here because as we're reading through this, Sue, I'm trying to figure out whether we need to have those contingency plans even if everybody is fully vaccinated.
Yeah.
And my reading is that, yes, you do.
I think, yeah.
Just in case in the future you have a situation where people I think where that might be a problem is if they become no longer fully vaccinated because there's a requirement put in place to have a booster vaccine and they don't get the booster.
Yep.
So with this memo, guidance was also published for surveyors. Surveyors will begin surveilling for the compliance 30 days after the issuance of the Quality and Safety Oversight Memorandum through a full survey for recertification or reaccreditation, federal initial surveys, or a complaint survey. Surveyors will be guided to focus on the vaccination status and the ASC policies to address vaccination for staff that regularly work in the ASC based on the phased-in approach described earlier.
So that's interesting because I hadn't noticed that before, but even if it's a complaint survey totally maybe unrelated, anytime somebody's surveying you, they're looking
basically if they're coming out, if CMS is coming out or the state is coming out or the accreditation organization is coming out, this is one of the first things that they're going to look at.
Yeah, and you were commenting that this is really going to be time consuming. So the more organized you can be and the more able to give the surveyors this information, the better off you're going to be because they're not going to be happy. So CMS expects all facility staff to have received the appropriate number of doses by the time frame specified in the memorandum unless exempted as required by law. Facility staff vaccination rates under 100% constitute noncompliance under the rule.
The ASC policies and procedures must be implemented within 30 days of the publication of this regulation and address each of the following components.
The ASCs must have a process for ensuring all staff, as defined above, have received at least a single dose or the first dose of a multi-dose COVID-19 vaccine series prior to providing any care, treatment, or other services for the facility and or its patients.
And I think probably one of the most significant parts of the memo is what follows. The policy must also ensure that staff who are not yet fully vaccinated or who have been granted an exemption or accommodation as authorized by the law or who have a temporary delay adhere to additional precautions that are intended to mitigate the spread of COVID-19. There are a variety of actions or job modifications a facility may implement to potentially reduce the risk of COVID-19 transmission, including but not limited to the following. Now, it's important to note that what they're saying here is that you can't just say, oh, they wear a mask. And that's all we need to do. So anybody that is granted an exemption, you're going to have to justify how you're protecting the patients and the other staff members by having at least some of these mitigation factors. And it's going to be up to the surveyor to determine ultimately whether they are sufficient. That's going to be an interesting thing because I mean, as a surveyor, I don't have any guidance yet as to exactly what, how many of these things you need to have. And I think it's going to be a case-by-case basis too.
So some of these actions include reassigning staff who have not completed their primary vaccination series to non-patient care areas to duties that can be performed remotely, like telehealth, telework, or to duties which limit exposure to those most at risk, such as assigning to patients who are not immunocompromised or unvaccinated.
Another idea is requiring staff who have not completed their primary vaccination series to follow additional CDC recommended precautions, such as adhering to universal source control and physical distancing measures in areas that are restricted from patient access. For example, staff meeting rooms in the kitchen. An example would be basically in those areas, they would not be allowed to be in those areas without a mask. If they were in that area and unmasked, they would have to be alone. Even if the facility or the service site is located in a county with low to moderate community transmission, very important.
And another one is requiring at least weekly testing for exempted staff and staff who have not completed their primary vaccination series until the regulatory requirement is met, regardless of whether the facility or the service site is located in a county with low to moderate community spread. In addition to following the CDC recommendations for testing unvaccinated in facilities located in counties with substantial to high community transmission.
And I think, Sue, this is probably going to be, it's not an easy thing to do, but it's probably one of the best ways and the least disruptive ways to prove that you're doing something more than what you're doing with those people that are fully vaccinated.
Well, I feel like almost all of the above, masking, trying to distance. Yeah.
Right. And another one, well, the next one, though, is something that you probably don't want to do, and you might want to do the previous one. So the next one is saying requiring staff who have not completed their primary vaccination series to use a NIOSH-approved N95 or equivalent or higher level respirator for source control, regardless of whether they are providing direct care to or otherwise interacting with patients. Now, that could be very expensive because that N95, you could go through, depending on how many patients that person sees during a day, you can go through it, many N95 masks.
While the organizations can choose what they require,
we should note that all of the accommodations or any of the accommodations that you make need to be addressed in the ASC policies and procedures, should be outlined in there.
Yeah.
Continuing, facilities must have a process by which the staff may request an exemption from COVID-19 vaccination based on the applicable federal law. This process should clearly identify how an exemption is requested and to whom the request must be made. Additionally, facilities must have a process for collecting and evaluating such requests, including the tracking and secure documentation of information provided by those staff who have requested exemption, the facility's determination of the request, and any accommodation that is granted. Note that staff who are unable to furnish proper exemption documentation must be vaccinated, or the facility must follow the actions for unvaccinated staff.
And certain allergies or recognized medical conditions may provide grounds for exemption. With regard to recognized clinical contraindications to receiving a COVID-19 vaccine, ASCs should refer to the CDC informational document, summary document for interim clinical considerations for use of COVID-19 vaccines currently authorized in the United States. In general, CDC considers a history of severe allergic reaction, such as anaphylaxis, after a previous dose or to a component of the COVID-19 vaccine, or an immediate, which would be considered within 4 hours of exposure, allergic reaction of any severity to a previous dose, or a known diagnosed allergy to a component of the COVID-19 vaccine to be a contraindication to vaccination with COVID-19 vaccines.
And what's very important here is that the medical exemption documentation must specify which authorized or licensed COVID-19 vaccine is clinically contraindicated for the staff member and the recognized clinical reasons for that contraindication. The documentation must also include a statement recommending that the staff member be exempted from the ASC's COVID-19 vaccination requirements based on the medical contraindication. So I don't know much about this, but what you're going to have to prove is that if there are 3 recommended vaccines right now, they have to be allergic to each of those 3. You can't just have a blanket exemption or a medical exemption because you have an allergy to one component.
Yeah, it has to be very specific.
It has to be very specific, right.
And a staff member who requests a medical exemption from vaccination must provide documentation signed and dated by a licensed practitioner acting within their respective scope of practice and in accordance with all applicable state and local laws. The individual who signs the exemption documentation cannot be the same as the individual requesting the exemption, as we stated above.
And ASCs must have a process to track and secure documentation of the vaccine status of the staff whose vaccine is temporarily delayed. CDC recommends a temporary delay in administering the COVID-19 vaccination due to clinical precautions and considerations, such as individuals with acute illness secondary to COVID-19 illness and the individuals who received monoclonal antibodies or convalescent plasma or COVID-19 treatment, as was specified earlier. I think one of the biggest takeaways from the memo is that CMS requires you to have a contingency plan in place also.
And so for staff that are not fully vaccinated, must develop contingency plans for staff who have not completed the primary vaccination series for COVID-19. The guidance is not clear as to whether you need to do this if all of your staff is already vaccinated. However, the regulation does state the policies and procedures must include, at a minimum, the following components, and one of those, as we read above, is contingency plans for staff who are not fully vaccinated for COVID-19. So we think you probably have to have that in place.
That would be, and since I'm a surveyor, that is my current interpretation of that particular section. So regardless of, and again, you might run into a situation in the future when they require boosters that this could happen even if you're fully vaccinated now.
Yeah.
The guidance states that contingency plans should include actions that the ASC would take when staff have indicated that they will not get vaccinated and do not qualify for an exemption. But contingency plans should also address staff who are not fully vaccinated due to an exemption or temporary delay in vaccination, such as through the additional precautions. Facilities should prioritize contingency plans for those staff that have obtained no doses of any vaccine over the staff that have received a single dose of a multi-dose vaccine. For example, contingency plans could include a deadline for the staff to have obtained their first dose of a multi-dose vaccine. The plan should also indicate the actions the ASC will take if the deadline is not met, such as actively seeking replacement staff through advertising or obtaining temporary vaccinated staff until permanent vaccinated replacements can be found.
So the memo goes on to outline how and what the surveyors will look at when they come on site. We're not going to go into any detail, though, as you can read that all in the memo.
Suffice to say that it is extensive. And as a surveyor, I must assume that this is going to take me at least an hour, going through the records and the policies. And that's if all of your staff is vaccinated. And a few hours if any of them are unvaccinated, including those with exemptions. So I've talked to Lori and Ann, who are other surveyors with our company, and they kind of agree with me that this is going to be pretty time-consuming. So let's talk about the different levels of deficiency. So the highest level is what we refer to as immediate jeopardy. Immediate jeopardy means that you are going to be ordered to immediately cease operations generally and have to take mitigating factors before you can open again. And immediate jeopardy will be called if 40% or more of your staff remain unvaccinated, creating a likelihood of serious harm, or did not meet the 100% staff vaccination rate standard and observations of non-compliant infection control practices by staff. For example, the staff failed to properly don PPE, and one or more components of the policies and procedures were not developed or implemented. So I guess the point there is you could even have 100% vaccination, but if they go through and see that you're not adhering to nationally recognized infection control standards and you don't have all those policies in place, you could end up with an immediate jeopardy. So the next level is condition level, and this is where the surveyors determine that there's such a high level of concern that they feel that another survey is going to be merited.
And this would be if you did not meet the 100% staff vaccination rate standard and one or more of the components of the policies and procedures were not developed and implemented, or 21 to 39% of the staff remain unvaccinated, creating a likelihood of serious harm.
And the standard level deficiency, which is a citation that just has to be cleared and a plan of correction created, would happen if
100% of staff are vaccinated and all new staff have received at least one dose, and one or more components of the policies and procedures were not developed and implemented, or did not meet the 100% staff vaccination rate standard but are making good faith efforts toward the vaccine compliance.
I think that's that was a lot to go through, and I apologize that we had to read a lot of it here just to be sure that we got this correct. Yeah. And a lot of the wording actually came out of the QSO, the Quality and Safety Oversight Memo, which, again, we provided a reference to in our show notes. It is very important, though, that you read through that memo as you prepare for a survey and as you develop your policies and procedures. Yes. You need to take this seriously. Sue, I think one of the challenges that I think we're going to find is, well, obviously the policies and procedures need to be done. But second, if you do have anybody that has a medical exemption, or if you're in a state that allows a religious exemption, you got to have very good documentation as to the approval of that. If it's a medical exemption, it's got to be a doctor that's signing off on it, indicating that he's reviewed the medical exemption and agrees with the decision of the practitioner. So that could be quite controversial, I think. And I think where we're going to have significant problems is really with those allergies and making sure that if they're granted an exemption because of allergies, that they are able to prove that they're allergic to each one of the vaccines. So.
And just a really important note with any of this kind of things, when you're dealing with possible, job issues with your employees, that you do consult with a lawyer.
Absolutely. So let's take a short break, and when we come back, we will visit with the staff of Ambulatory Healthcare Strategies during their fall 2021 retreat, where they discuss what is going on in the regulatory world, recent challenges and how to meet those challenges, and how the podcast and AHS is adapting to provide you with the help you need to comply. Our listener patron program, also known as ASC Central, has really taken off over the past 12 months, and we are so grateful to all of our over 100 members. Our patron members help support our efforts here on the podcast and get a number of great benefits also. The ASC Podcast with John Goehle is the longest-running podcast dedicated exclusively to the ASC industry. ASC Central provides members with a wealth of management tools and resources, including regular members-only Zoom sessions with John and other members to discuss relevant topics, quarterly Zoom meetings where we update patron members with important issues in the ASC industry, periodic study sessions for leaders that are planning on taking the CASC or CAPE exam, and access to a large database that includes federal regulations, interpretive guidelines, and the state regulations, checklists for administrators and nurse managers, example meeting minute templates, example policies and procedures, budgeting and financial projection tools, risk assessments, and example forms, and much, much more. Members also get discounts on books written by John Goehle, ranging from $10 to $80 per book, and can even schedule a personalized mock survey with John and save over $1,000. For more information and to access this additional content, please visit ascpodcast.com or asc-central.com. So this is John Goehle. I'm here at our 4th annual Ambulatory Healthcare Strategies retreat here in Spencerport, New York. I cannot believe, as I'm sitting here today, the crowd I have around me. You know, when we started this out 4 years ago, it was a Christmas party. And I think there were 6 of us here, right? And today I'm sitting with, 14 of my colleagues here from this company, as well as some people that are joining us remotely from North Carolina and from Lockport. And then we have, Ann Geyer here from Florida. So I do want to, what we're going to do is I'm just going to go quickly around the room to have everybody introduce themselves with the company. And then we're going to ask some questions and talk a little bit about some of the discussions we've had regarding the ASC industry. So starting with Alex over there.
This is Alex Borneman, Director of Operations with Ambulatory Healthcare Strategies.
I'm Amy Durbano, Regulatory Consultant.
And this is Sue Cronkite, Senior Nurse Consultant with AHS and co-host of the podcast.
Mary O'Day, Consultant.
Mike D'Ambrosio, Regulatory Consultant.
Zach Kellerius, Financial Consultant.
Tony Lyons, Financial Analyst.
Judy D'Ambrosio, Director of Education and Senior Consultant.
Laura Plummer, Regulatory Consultant.
Lori Rodricks, Clinical Director.
Director of Clinical Services.
Jenna Alvarez, Senior Consultant.
This is, of course, John Goehle. I own the company. Go ahead.
Ann Geyer, Chief Nursing Officer.
Kim Masters, Life Safety Support.
And Kathy Fody, Senior Nurse Consultant.
So we have a lot of new people with us here, so I'm having to lead them through our protocol here for the podcast, so bear with us here. One of our goals here is to kind of discuss the changes that we have decided upon for the next year as we prepare our services, the service offerings that we have at Ambulatory Healthcare Strategies, to make sure we meet the needs and requirements of our clients. But I thought we would do that by just introducing some of the challenges that we've had over the last year. And let's just start with leadership. I think one of the challenges that we've had coming out of the pandemic is the loss of senior leadership in many, if not most of our organizations, as well as the challenge that has driven clients to us. So we recognize now that many senior leadership people are retiring, leaving the industry, and it's leaving a huge gap. And as a result of that, we have been making some pretty significant changes in the educational offerings of the ASC Podcast, including our leadership programs such as our boot camps. But I would just like to open this question up to everyone. What are some of the leadership challenges that we have been experiencing? And I'm going to start with actually Alex. Alex, talk a little bit about some of the challenges you've had with some of your clients recently.
Yeah, I think a lot of it stems from a lot of the leadership getting called into the operating rooms, and especially one of my specialties is life safety, and life safety items are pretty low on their on the nurse manager or the administrator's list if they're getting called into surgeries and having to actually work on the floor.
And they're having less and less time to be able to take care of the things that are related to quality improvement, seeking strategic direction for the organization, preparing for surveys, for example, and making sure that all of those checklists are up to date, and even making sure that all of your staff are getting their competencies done, correct?
Absolutely, yeah.
I'm going to pass it on to Judy. Judy, talk a little bit about some of the challenges that you've seen. You also are a senior consultant that deals with some of those, some of these issues, and you've had some significant problems also.
Yeah, well, we've all had significant problems. But the biggest thing I've come across this year, and I'm sure it is, post-pandemic related, we have had succession problems. We have nurse managers or administrators look at what life became after the pandemic and said, you want to know what, I'm going to retire, or I'm going to walk away from this for now. And not that I don't get it, I completely get it. But your average center is busy and doesn't really have succession planning as something that's important to them. So here we are now. I have a brand new nurse manager, has never had the job before, is also working clinical like Alex says, because now there's just not the staff that used to be. So that poor nurse manager, while she's learning to do a job that I always said was unbelievably difficult and unappreciated. So now she's trying to learn that, be a floor nurse, be a surveillance nurse, be everything all at once. And as a company, we're real helpful. Like, we do everything we can to support these people, but I think we've gotten to the point where even our support isn't enough for some of these centers.
Yeah.
And that's worrisome, I think, moving forward.
Jenna, you deal with our startups and just getting them through the beginning when often they have almost no resources or no resources to begin with. And then trying to recruit people into those positions has been no easy task recently. Can you talk a little bit about what those challenges are and how you've been helping them, to get to the point that they need to be at in order to be able to actually start operations?
I think one of the biggest issues we're having right now is people are building these beautiful new facilities, getting all the construction done, and now they're finding that they're sitting waiting with their nice shiny new buildings because they don't have the ability to get the equipment in time due to the supply chain issues. And so that's where we're seeing delays right now, whereas you have the normal construction delays that you're going to have, or most people plan for a little bit of potential. But now it's, I have one surgery center that can't get the lights for the OR, and so they're just, they got the keys this past week. I don't think they're going to probably open till March at this point because they just can't get what they need to open. Staffing, again, it's hard to even plan for staffing because you don't even know when you're going to open your doors. So they're working on finding staff, but where are you finding staff? No one can find staff these days. And luckily, the centers that I'm currently working with have good administrator and nurse manager right off the gate, which is a huge benefit because we don't always have that sometimes. And that's, if you don't have a strong nurse manager or a strong administrator when you're starting up, it's really hard to put the right pieces in place. So I think what has surprised some of the centers is how much work goes into putting things together, like your policy manual. Like, oh, but you're providing the policy manual. Yes, I'm providing a template for the policy manual, but you are the ones who are determining how your center is running on a day-to-day basis. And there's a lot of input that we need from you to finish that policy manual. So we've been meeting for an hour or two a week for the past 6 to 8 weeks. I don't even remember how, going through a chapter or two a week. And then, she's going back through the administrator and the nurse manager, whoever's working on it with me, is going back throughout the week and getting answers to all the questions that come up during those conversations. And so I really enjoy doing it that way because I think it brings up a lot of questions of, oh, well, we don't have that contractor. Oh, I don't know how we're going to do that. So
Well, often those people that are being brought in from, these startups have little or no experience in the ASC industry. They might be coming from the hospital
Or an office space.
or for an office-based practice and learning all the things that they need to learn in addition to dealing, that's something that they'll have to deal with for the rest of their careers, with that organization, on top of having to learn something, dealing with, a one-time thing, learning all the life safety issues that they have to deal with the construction, getting past that initial survey, usually 2 surveys, one for licensure, one for certification, is no easy challenge. And of course, ultimately we're going to talk about when we get to the end here is, what are some solutions out there, some suggestions as to how to deal with that. Mm-hmm. We have 2 individuals who just joined us who were leaders in their respective organizations, and they provide a unique perspective. I'd like to introduce Tony Lyons, one of my dear friends. Tony is responsible. He is to blame for me being in this industry because 30 years ago when I first met Tony, he was the chief financial officer for a major health system in the western part of New York State. Tony, thank you very much for introducing me to this industry. You are totally to blame for this. But, later in your career, after you almost retired from the hospital environment, you chose to go with a surgery center. And you've recently kind of retired from that organization. But you got that organization through the pandemic. Can you talk about, coming from a hospital environment? I think that's probably one of the more interesting things. So many of our people now are coming from the hospital environment. What were some of those things that you had to deal with that were totally different in the ASC environment from what you experienced in the hospital?
Well, one thing in the ASC environment, not only myself, but many of my nurse employees also came from the hospital environment. And they were less self-sufficient because there are so many supporting departments in the hospital.
Right.
Risk management, and infection control. And so people
credentialing,
yeah. People would come in with the clipboards and take care of this and that. And, the nurses would make fun of them. But now here they had to do things that they didn't wear more than one hat to take care of the patient. So that was a challenge, and it still is a challenge. And some of them have been there for years to orient to those types of things. It was kind of like in the hospital industry itself, when a nurse would be promoted into a management level. Often we neglected to educate them. They often thought they would be now super nurses, rather and not realize the administrative things they need to pick up to do. So that's a challenge. And then of course you're self-sufficient, not just in one position, but the whole entity.
Right.
While it's really nice to be have the whole operation as an entity that's light on its feet compared to lumbering hospitals that are hard to get anything done, you still had to take care of everything. And the credentialing for one doctor is no different than that credentialing for an Article 28, at least in New York State, for a hospital. So you have a lot of less doctors, but taking care of the credentialing, the personnel files, all of those types of administrative things. I was, mainly from the finance and administrative side. But then at the same time, as an administrator, having to work with all of the nurses, all of the, I was the driver for the quality assurance. I was the driver for all of those things. So I can see where being a nurse, nursing medical background in that position that I had has its advantages, but then the administrative side would have fallen off. So it's quite a challenge to get the right blend of person to take a lead, I think, in these organizations, and then to build the critical positions of, a nurse manager, administrator, and medical director, to as well as educate your small ownership board about your responsibilities is it's challenges that are really a lot different than the hospital environment where you have so many supports and you're kind of sitting on top of the deep blue sea, where here this is your own fishing bowl and you got to do the whole deal. So.
Well, you brought up a very good important point is that there isn't owners in surgery centers are often not knowledgeable about how restrictive or how regulated they are, even if they've been through it before. And they don't always understand where we're heading right now, which is toward more regulation, more control and tougher surveys. A frequent comment that we're hearing right now is, oh, we passed the survey fine last time, or they've never brought that up. We might point something out during the mock survey. I'm looking at Lori here. Even though her microphone is down. Is that on purpose or?
I think it's tired.
It's tired. So Lori will point things out to to an organization, and they'll say, I've never had to deal with that before. Don't worry about it. We'll pass the survey. And we're saying, no, maybe the surveyor will catch it. Maybe they won't. But do you want to be the one to find that out, during the survey?
Yeah, no, it can be very annoying and also discouraging. Because if you're trying to give advice to a center to only make it better for them and their patients, and they choose not to listen, all we can do is educate. And that's, I think, a good portion of our job at AHS is that we educate people. How to tighten screws, how to wash their hands,
If only everybody could see the behind the scenes here to pull off this podcast in our high tech organization where I just pulled a screwdriver out in order to fix that whole microphone problem. Yeah. Kathy Foti, you are relatively new to us. You are joining us remotely from North Carolina. You just joined us, literally within last month or so, and you're going full-time with us very shortly. But you came as the quality improvement nurse, leadership position in a facility up in New Hampshire. So talk a little bit as you were, you were in the hot seat during the pandemic and dealing with ongoing quality issues that, of course, were enormous during the pandemic. Talk a little bit about some of the challenges that you had in that hot seat and also dealing with those the staffing challenges that were continuous also.
The biggest challenge probably for our facility, as well as many of the facilities in New Hampshire, was continuing to do safe patient care while dealing with your own staff having quarantine issues or other personal issues, which created staffing issues. I think in not only the staffing end of things, as we've discussed today, I think we've all found the fact that people have decided that the work-life balance has changed when they wanted to leave. And so on the same line that Judy has said, the succession, planning out how the facility is going to bring on good management. How are we going to train these managers overall to take the place of somebody that's been there 20, 25 years? This younger generation has really, really great, educated, knowledgeable staff, but the component of regulation, the component of mentoring someone is so important. And I think that's looking in the future is a great service that one needs to have.
And it's almost like you were setting Ann Geyer up for the next part here. And we didn't even plan this, Kathy, but thank you very much. And again, I appreciate that, we got such a wide mix of individuals here. And as we finish up this leadership segment, I'm going to turn it over to Ann to talk a little bit about, Ann is really, somebody that has worked most of her career in mentoring individuals and making sure that they put themselves in a position that they're ready for leadership. Talk a little bit about, where you see we're heading right now and what can be done to try to prepare people for that future.
Thank you, John. I think one of the first things is you have to identify good potential successors. So every day that you go into work as an administrator or as a manager, quality manager, infection preventionist, be on the lookout for who could step into your shoes. Should you retire? Should you get sick? Should you decide that you've had it and you just can't take it anymore?
And once you've identified those people, then you give them all the tools you can to train them. Not everybody wants to move into management. Do not beat a dead horse into saying you will be a manager, because they'll be a bad manager. So identify people who have the potential and then give them every tool in your toolbox to allow them to succeed. I think the biggest thing you can do is if you set somebody up for failure by not training them adequately. And if you ignore the educational sessions, if you ignore the meetings that they could attend, if you ignore the introductions through networking, which John and I both love to network and we know everybody, you owe it to the people you're training to give them those same opportunities. And then set high levels of expectations for those people. Because a lot of times, if you set the bar high, they'll achieve what you ask them to do. If you just maintain status quo, that's what they'll do, because they don't know that they can do more. So challenge them. People think that we're not a regulated industry. I mean, there's a huge misconception out there that ASCs are a piece of cake. You come to work, Tony addressed it. You get people, all of my colleagues have addressed that. People come to work from a hospital and they think, oh, this will be a piece of cake, until they find out we're standalones. We don't have those departments that back us up. And if a piece of equipment dies, you're it. You either become a mechanic really quickly or you have to abort the case. So your managers need to know that. They need to be trained on what to do if this happens, because we don't have immediate response teams. We are heavily regulated. I think COVID has wreaked havoc on us in that right now we're dealing with the COVID vaccine mandate. It's on again, it's off again, it's on again. Do you have a plan B for if all your employees aren't vaccinated? I look at centers, I'm a surveyor for AAHC, as are Lori and John and Jim Masters. We go in there and they don't have a plan B. They haven't thought beyond the fact that, well, if it happens, it happens. Yes, but 13 of your employees aren't vaccinated. Are you prepared to shut down cases? That's all part of the mentoring program. You're a standalone. You have to know how to make decisions quickly. And quickly is a key. We don't manage by committee. Would you all agree on that? Everybody around.
Absolutely.
We don't have committees in surgery centers. So you have very small group of people that make that decision. And then sometimes it's your administrator. And they have to act quickly. And they inform the board and say, but we've got to do something right now. And then they act on it. So mentoring, training, educating, it's huge. But start working now on who in your center can step up to that plate and start giving them the tools.
And we're going to talk about some solutions that you can do, free solutions, moderately priced solutions, expensive solutions, that whole gamut of those opportunities as we finish up. But I wanted to move on to life safety. Jim Masters has joined us here. He's a life safety surveyor, a former New York State surveyor, and he has a lot of knowledge in this area. And of course, Alex Borneman, who also works in the life safety side for us, is here too. Life safety has become a huge issue. When we look in the last year, in the last surveys that we've had, the challenges that we've had, many of those surveys have really had major life safety issues identified. By the way, issues that had always been there. I mean, these are not necessarily issues that have been newly created, but issues that have always been there, but now they're coming up as a citation in the survey. Jim, do you want to start talk a little bit about the experiences that you've had recently and what that means for the average surgery center?
I can. So, let's start out with a new center, because some statistics were given to us at the GU meeting for AAHC, and I think, Ann, you were involved with that meeting as well. But the statistics showed that with early option surveys and initial surveys for new centers, that life safety was the number one factor in stopping them from getting their accreditation. And it was typically like a firewall issue or pull station related to the fire alarm system or the EES system. So these life safety systems within the buildings are actually preventing them from getting their team status on their. So,
Jim, let me stop for a second just to make sure our listeners understand. What that means is that when you go through an early option survey, and there is a condition level citation, in other words, a major citation there, you fail that survey and you will have to go through the whole cycle again, which means that you will not get your Medicare certification. You will not get paid by Medicare until you go through that cycle again. So what you've just described, of course, is a very serious situation, and it's going to cost a substantial amount of money for that organization. I'm sorry to interrupt, but go ahead.
No, that's an important factor. And believe it or not, some of these citations are really relatively easy fixes. However, because it is a Medicare deemed status survey, it's wrong at the time of survey and there's no time for correction. So it's most important to have everything in place prior to the survey. So that's with the new center. And with existing centers, the answer you get is always, well, it's been this way forever, but doesn't mean that it's compliant right at this time. So it's always important to go through your life safety systems, EES, net gases, sprinklers, fire alarm systems, training, education, fire drills, disaster drills, exiting requirements, the entire gamut of life safety checklist in order to, make sure that you're compliant for the survey.
Alex, I'm going to look at you for a second here because I'm going to play the devil's advocate. Alex, you're a life safety surveyor, and you just cited me because I don't have an emergency electrical system that's compliant. I got a couple breaches in the firewalls, but Alex, I am so small. I'm a tiny little center. I just do general anesthesia. I don't do anything serious. Like, I'm not a hospital. Why do I have to do these things? Go for it, Alex. I only do general surgery. I mean, we can't make this stuff up, right?
Right. Yeah, we've unfortunately had many of these conversations, and really the best answer is, well, and usually it comes out of why haven't I been cited for this in the past if it's really a problem, like Jim was saying, and the answer to that is life safety surveyors are getting a lot more savvy.
And they really don't care that you didn't pass it. Right. It's not relevant. Don't even bring that up.
Right. Not relevant. Unfortunately, as an AHJ, AHC has the right to, every survey is part of that process of them making the determination about whether you meet the standards and the codes for life safety. And if you're one of those centers where your systems are borderline, you're running a risk every survey. And that's why your documentation needs to be really, really good. You need to have risk assessments in place. But yeah, every survey is unique, and every surveyor comes in with different specialties, different backgrounds.
Right.
You might have a HVAC guy coming in, and he's probably not going to know much about your electrical system.
Right.
And he'll do a preliminary, look over it to see if there's any major red flags that he can see. But, and some surveyors might be a little bit more lenient and might say, oh, well, clearly you had a in-depth conversation with your state about this issue. They're okay with it. I'll be okay with it. Not every surveyor is going to say that.
Go ahead, Tony.
Well, just on this point, when a physician reasons that they're not a hospital,
Yeah.
it shouldn't be such a big deal. Actually, it's going to be a lot bigger deal for Medicare, the state, or the accrediting body to close the hospital down.
Yeah.
It's going to be a lot more heavy lifting to close a hospital down because it's an infraction of regulation. But in fact, as a smaller provider, as a surgery center, you are at risk.
Yeah.
You are at risk to be closed down, and they won't blink because there's plenty of other services.
It's a lot less paperwork to shut
A lot less paperwork,
Yeah.
and no one's going to be crying that much about some doctors losing their ability to practice at a surgery center where they can go to the hospital.
Yeah.
So the answer is you've got a lot higher risk than a hospital.
That's a very good point.
I just said that because that isn't how they think about it, but that's really smart.
Yeah. So we actually have experience with that, Tony and Alex and Jim, is that, we've been called into situations where we've had a couple of situations we've had to deal with recently where we've been hired after the place was shut down, and we've had to go back and help them get back up and running. And I'll state that we have two of those situations. One shut down in January of 2021. We got them open finally by, I think it was April, late April. They were losing like $200,000 a month during that time frame. A lot of money that they'd lost because of their failure to to follow the conditions for coverage. One center was closed in August of 2019, and they are still not open. And those were life safety issues there. So we're not making this stuff up. But more importantly, we have situations right now where people have come very recently, a center that had a glass wall into their surgery center. They've had it since the beginning of that organization. And by the way, you shouldn't have glass walls in your opening to a surgery center in general. And they'd never been cited before. 3 surveys, never been cited before. And in this survey that just occurred about a month ago, they were told that they had to replace it. And of course, the doctors are saying, "Oh, we're wavered under that," or nobody brought it up before, so we don't have to worry about it. Jim, you want to talk a little bit about that? How much as a life safety surveyor do you take that into consideration before you cite them?
Well, so each state is different, and some states have certificate of need program where the state surveyors will accept certain components of the separation walls, but this is CMS. This is from the federal side, so it's a little more stringent than what the state might have allowed. So it's definitely a compliance issue for separation for the glass walls. In some cases, they would have a glass wall with sprinklers on either side in every vein of the window or the wall, but it's only acceptable in an atrium situation where you have at least 2 stories high. So it's been. A lot of centers have been allowed to continue with that. However, going forward with AAHC, they are not going to allow it, and they have to have the actual firewall built.
Yeah, so be careful moving forward about that. That if you do have that type of situation, you might want to bring somebody in. I do want to finish this section up by just bringing up the importance of having Jen, Jenna, you've been running into situations recently where I did a walkthrough. You and I did a walkthrough at a new site. We were told not to worry about life safety because it's a hospital-owned surgery center, and the hospital is on top of things. They know everything that's going on, and there won't be any problem. And I walked through. And instantly, I'd say within, because I'm so smart, of course, my point being is this was so obvious that within 5 minutes, I already identified 3 items that literally would cause them to fail that survey. Fortunately, we were there and we were able to step in.
And we were early enough in the process that we were able to fix the issues with
Right.
minimal cost.
Yeah.
Yeah, there wasn't, because they weren't totally.
It's still gonna be expensive, but they're not like tearing down walls or
Right.
anything.
So here, I just wanted Jim and Alex, just kind of a quick and dirty bullet point. What are some things that you can do very quickly? Obviously, I think our real recommendation is get a life safety, mock survey in before your next survey, and certainly before you open a new center. I can't imagine in today's environment not doing that. But if you don't do that, what are some quick and dirty things that you should be looking at? I'll start with Jim.
So, we look for the logs. We look to see that the logs are maintained for all the various PMs that they do on their various systems. And if we can see that they're doing a good job of their weekly, monthly, quarterly, annual checks, then, you get a little comfort zone in knowing that you're dealing with a center that's well maintained and they're doing their part on the life safety issues. And then it comes to the contractors' maintenance or third-party contractors that they're bringing in for the med gas system, the EES system, fire alarm system, sprinkler systems, all the various components, generator maintenance, generator testing. So, the list goes on. But if we can see that they're doing a good, comprehensive maintenance package and the logs are in place, it kind of gives the surveyor a little comfort zone to know that they don't have to dig too deep to see exactly what's going on. Whereas if documentation is poor then the surveyor is going to dig into those areas, and that's where the problems are going to come up.
And also, Jim, one thing that we need to remind people of too is every time the surveyor comes in, they're going to look also not only the stuff that's happened the last couple of years, but they're going to want to look at any installation records to make sure you're still maintaining those things. So don't throw out all those things that you got, when you first started the surgery center up.
Absolutely. Any new furnishings, flame spread ratings on new curtains and chairs and carpets if they have them, various things. You want, fire door inspections is kind of a new thing on the market, and they want to make sure they're keeping up with those annually, and really records of everything. If they expanded or replaced the generator, you want all the documentation from the initial build out or replacement.
Go ahead, Alex.
Yeah, and going off of what Jim said, in terms of contractors, there's a lot of contractors that solve a lot of the problems at ASCs, but there's also a lot that cause problems.
Yeah.
So
or they feel that, hey, I got past the state inspection, I got past the local inspection, I'm all set. I don't want to do anything else.
Well, and part of when you bring people in from the outside, they don't always know the regulations of your ASC. And so looking, especially for existing centers, but this is true even for new centers, looking at your firewalls to make sure that, your IT company or whatever, your HVAC company, whoever's been running pipes or wires through your walls in the last 3 years since your previous survey, or since the fire marshal came in and checked your walls if you're a new center, making sure that there's no new penetrations, and then also same thing on the electrical panels. Oftentimes you get a new piece of equipment and you'll have it wired. And they might not, the person wiring it might not know your regulations and what branch that needs to be on. And that can cause major problems if it goes on the life safety branch and it's not supposed to be there.
And labeling in all branches, always an issue during a survey.
I wish maybe I'll be able to figure out where all the circuits are.
Correct. It's always, regardless of what type of EES system they have, the labeling is probably number one issue. They might have everything they need, and it could be properly installed. However, the labeling doesn't provide that information to the surveyor. So it's a number one ticket item.
I did want to mention something that's come up recently too, is that in the last two deemed status surveys that we've had, the life safety surveyor and the health surveyor have not been there at the center at the same time. Very unusual circumstance. In the past, it was unknown. One survey that just happened, the separation was 2 months. In other words, the health surveyor was in there 2 months before the life safety surveyor was there, which meant that there was a delay in the report for 2 months. So be prepared, because, and again, this is staffing related. They're, the surveyors such as Jim, are overwhelmed. How many surveys did you do in the last year, Jim?
Oh, with AAA and with you guys, over 70.
Over 70 surveys in 12 months. It's amazing that you haven't collapsed. Sorry. But be prepared for some unusual things like that. Jim, thank you. So we've just discussed challenges that everyone is facing right now in the industry, the issues in trying to get through a survey, the life safety challenges we have, and of course, especially, and really what it comes down to in the end, the challenges in developing leaders for our new situation right now, and raising them and developing them into effective people for our operation. So let's talk a little bit about what we can do. And let's just start by the stuff that everybody should be doing anyway, relatively totally no cost, as well as those things that are relatively inexpensive. We'll start, let's push the podcast. Obviously, you're all listening to the podcast right now, 145 plus episodes. That's a great resource for you. We have slowed down a little bit this year because of the challenges we've got. We have the same issues you all have out there of staffing and trying to keep up with this. We do promise in 2022 that we'll try to make up for that and continue to provide the great content that we've been doing. And also, keep in mind, if you're a member of the patron program, there's a lot of great resources that you can have, including weekly drop-in sessions that you can talk to us. And we have a lot of fun. Ann and Lori, you spent a lot of time on those Saturday morning sessions, and I have to admit, and Sue too, of course, we have fun and we have a nice discussion. It's almost like sometimes a great opportunity to get to know our colleagues and talk really big picture items. And then the other thing that I really want to encourage people to do is join the ASC Association, please. It's a great organization, provides a lot of great resources. Yes, the membership fee is expensive, but there are a lot of things that you get for that membership, including access to emails, newsletters, articles, an online forum that you can post, questions. For the cost, it is an incredible benefit, as well as being able to access webinars and live conferences. So definitely think about that. And if you're in a state, if you're lucky enough to be in a state that has a state association that's active, please join that also, not in place of, but also, because I think that you'll find that the benefits of having somebody or an organization that helps you get through the state regulations, as well as the opportunity to speak to and mingle with people from your own area would be very helpful. So let's face it, sometimes you're going to be in a situation where that's just not enough, that you don't have the time, or you can't find leaders in your organization that have that experience to even be able to know the questions to ask. So let's start with leadership training. Lori, and Sue and I, and of course, our whole team is involved in mentoring of all of our clients, but we do put on boot camps and training programs through the ASC Podcast. All that information is available on ascpodcast.com. Please avail yourself of those programs. We do 2 boot camps a year for nurses. That's in May and November. And we do 2 administrator boot camps. Next one's coming up in February, and the one after that will most likely be in August. As well as self-paced versions of it where you can sign up and just do it at your own leisure by watching recordings of that. They are not, inexpensive options, of course. That's because there's a lot that goes on. It's not only watching and or participating in these 4-day conferences, but also ongoing mentoring online, emails, and access to a huge database of information. So you'll never go it alone, if you have access to that. But, sometimes, I'm looking at Ann here, she's sitting next to me. Sometimes that's not enough, Ann.
It's not enough.
It's not enough. So one of the things that we've been talking about the last 2 days here during our annual retreat is, what can we do for those organizations that, first of all, really take this to heart? I mean, you've got to have really good leaders, really good owners that are willing to put the money into invest in you. So we have developed a new product that we are rolling out now. As we sit here today, we don't have a fancy name for it, right, Ann?
No.
But it is a mentoring program where you basically sign up with us, and on a monthly basis you pay. It's a fixed fee program, but you have access to all the resources that we give as part of any of the boot camps, as well as one-on-one mentoring. Sometimes we can even include one-on-one, on site too. Right. Like maybe you want to do a mock survey. But Ann, why don't you just talk a little bit about the things that we've discussed on that and how that would look?
It all came about almost accidentally. And the first one, because I've just been with the company, John, since June 1st.
That's true.
And it was kind of accidental because someone had heard me speak at a meeting and said, can you help a surgery center out? We want to work with you and we don't know what we don't know. So that led to our administrators leaving, is taking all of her information with us, has not given us any transition, and we're lost. We need you to help mentor the administrators. So all of a sudden we developed this mentoring program, which I love to do anyway. But part of it is almost hand-holding you through the process, trying to explain to you because you don't know the questions to ask. You have no clue what to ask because you don't know what you don't know. And that's what they all say. So you start off with all the tools that I have are now for their use. and we share those tools. And then I start making the connections. So I was living in South Carolina for a long time. One of my mentees is in Myrtle Beach. And so I then networked her with some of the other people in South Carolina, got her involved with the South Carolina State Association. So sometimes she doesn't even call me now. She knows directly who to go to at the South Carolina Association to ask certain questions pertinent to her. And then it grew from there because now it's expanding. We're New Jersey and I'm helping 2 centers and just have the 3rd all say the same thing. We're new to the administrator's role. We don't have a clue. And so we developed this program. Basically, it's just a roadmap for here's what you're going to need to know. And here's how you get to that point where you feel comfortable, realizing that we're your safety net. So if you get into a situation where you look at what you're supposed to know and say, I don't even know what I'm doing with this, then you call us right away and we help you walk through it. This company has a wealth of education and knowledge behind it. So if I don't have the answer, and I think every one of you in this room would say, we don't have the answer, we'll get it for you within 24 hours. Because we all know people that we can call, we can access for their information. And you get back to them. Well, all of a sudden your credibility builds. The next thing you know, someone else is calling saying, so-and-so said that they didn't know what they were doing and you're helping them. And that's where we are today. And it's really been a lot of fun, but it's created a whole new enterprise for us that we hadn't even planned on. At the last meeting, this never even came up.
That's right. And it's something that we recognize fills in that gap. And we're going to talk in a minute about how an organization such as ours can actually do a lot of the work that you might, as an administrator or nurse manager, might do. But this is that in between. This is almost a time limited. I mean, as long as you want to receive these services. But, we make the agreement. It can be extended. It can be shortened, whatever it is. We don't make long-term agreements. So this is.
So once you feel like you've learned everything you need to know, you can say, Ann, thanks a lot. We'll see you at the next ASC meeting. And I'm happy when that happens because I feel like I've done my job. On the other hand, some of them just don't want to let go. For those of you that have ever mentored somebody in the surgery center, sometimes it's knowing when to let go of the people that you're training. They have to fly on their own. Right. And so there's an element of that too, where they are flying on their own, but they know you're there if you need to be.
I want to point out too that so when we develop this program, it's not it's for all levels. So you've got administrators that need to be mentored. Now I'm looking at Lori, even though Ann, you're involved in nurse managers too, but I'm looking at Lori because Lori does the nurse manager boot camp. So another option that you have is to be mentored through the nurse manager program. We literally do this with every single one of our clients. All of our nurse managers go through a mentoring program. It's not fancy. We just basically, send people in on a regular basis. And of course, we're available at all times. So as we go forward, we might be doing a little bit more formal. I think we are talking about a little bit more formal. But, Lori, just talk a little bit about how this would be useful for a new nurse manager, coming into the industry and what a mentoring program would need for them.
Well, I think it's the important part, is that make sure that you realize you're not alone.
Yeah.
No, that's
I think that's the biggest takeaway, is that it's not.
And you don't have to reinvent the wheel.
Yeah. And, you're not just getting a book and here you go learn. Because that's how many of us in the world here had learned to become the nurse manager or the nurse administrator or whatever. It was just go for it. And so, like you said, you offer so many tools and, our email, if you have questions, you can reach out. There's a person on the other end usually, that responds. But then
not on Christmas Day, but most of the other
you
time.
Never know. But the other thing is, if you're able to attend the boot camps when they are live, now you're also making connections with other people in the same boat, which is really good because networking is huge. I still reach out to people that I've met 100 years ago.
Yeah,
and it's great. It's just knowing that you're not by yourself. And that you can do it. And then maybe asking, because maybe you can't do it. And someone sometimes has to let you know that you're in over your head. But, the whole point is, like Ann said earlier, it's not just if you're the new nurse administrator or the new nurse manager, you want to be able to have the tools to be
a success.
And it's not limited to administrators and nurse managers. Alex, I'm putting you on the spot right now. Alex has been dealing with the life safety issue all day long during our boot camp. I'm sorry, or during our retreat here. Alex, I mean, unfortunately, Jim had to leave us. He had other things going on. But can you just talk a little bit about what you think a mentoring type of relationship with, I think it could go two ways. You know, maybe you have an environmental services person in your organization who's just going to need some life safety help, because this is, let's face it, it's as serious as a nurse manager and an administrator. We just don't take it that seriously. And of course, the other challenge is that you might need mentoring from a life safety person to be a nurse manager or an administrator too. So, you know, now this is in early development as we speak about it, but just talk a little bit about what you think, how that might look as you're mentoring somebody through these responsibilities.
Yeah, so there's kind of two parts to mentoring life safety as I've done it and as it's been done for me. Part of that is getting the person who's getting mentored in touch with the code books, getting them to have the actual resources at hand so they can access the answers on their own. But the second part to that, of course, is also mentoring through, established standards, because the life safety codes are very complicated. Every life safety surveyor that I know always says, no survey is all inclusive. There's always more to learn. Every life safety surveyor goes out on site and learns something new every single time they do a survey. And
we'll catch things differently
differently. So it's a constant road of improvement. And I truly believe, I mean, there's been mentors like we were talking about Jim Masters for me, that is how people learn about life safety is through mentoring. It's usually pretty informal, but yeah, if you've got an environmental person on staff, they definitely should get mentored by somebody outside the organization, hooking them up with somebody that knows life safety in and out, who's been doing it for years, is definitely an important thing to do. Or if you're an administrator and you're doing all the life safety things, having somebody to go to with questions and to get answers from is very important. I mean, spending half your life making logs for for the testing that you're doing is that's not a fun thing. And there's organizations that have logs available, and you don't have to recreate the wheel, as they say.
Well, and again, I do want to point, I mean, this sounded like a sales pitch to a certain degree. Of course, it is, but recognize that, you can do this. I mean, if you have somebody else that you have met in a conference that's willing to mentor you through this thing and through all these things, for goodness sake, take advantage of it. But I'm going to look at Mike D'Ambrosio right now, because Mike is an example of kind of somebody that's being mentoring right now. Mike joins us with a lot of OSHA experience, immense experience from his industry time. And he, what's that term? Retired. I don't understand that term, but semi-retired. So Mike retired recently and joined us. He is, as was mentioned earlier, the husband of Judy D'Ambrosio, who's been with us quite a while. But Mike, one of the things that you are working on is learning about life safety. And it's not something that you actually have a lot of experience in, but of course you enjoy. You've been picking up on quick. Just talk a little bit about the experience and how valuable it is to have the mentoring relationship that you have with Alex and with Jim.
I think as Alex points out, you can't know everything, and the way to start an industry is to go to somebody that has the experience, right? I come from a background of manufacturing, so risk assessments and things like that I'm familiar with, but not in this type of environment, a standalone surgical center. So it's been very informative to me working with Alex on risk assessments and understanding that, and getting mentored by Jim, understanding where to go to look for the codes, and getting a base, a ground of where to start. I think it's the fastest to actually dig into it. I had the pleasure of traveling along on a survey.
Yeah.
And
It's
learn.
funny how you use that term pleasure.
Yeah,
It seemed that way at the time.
Yeah, it did it all.
But in that experience, I think I gained quite a bit of knowledge, much more so, than just looking at the regs. So that mentoring really can connect and really bring up that learning curve in short order.
Well, and you bring up a very important point is that if we shift the way we look at surveys to that's being a mentoring, I mean, no survey is going to be perfect. You're going to learn something from each of those and use those surveyors to get as much information. I know when you were on that life safety survey, you asked a lot of questions of the surveyor, gave you a wealth of information and obviously helped you through. And it's a different attitude than trying to fight every single thing that's brought up, learn from them. And that way you're prepared in the future.
Exactly.
So I'm going to shift. I'm looking across that. Oh, and there's Jim.
Hi, Jim. Hands on the wheels.
That's right. Hands on the wheels, Jim.
I'm in the parking lot.
So I'm going to shift lastly to an area that we, funny as that sounds, the company was started with a heavy focus on financial management. And we thought in the beginning that we would be focusing on financial services to ambulatory surgery centers, and we ended up veering off into regulatory. However, as I'm sitting around this conference table here, I have 4 people with finance background. Myself as a CPA, Tony Lyons just joining us also as a CPA in his past life. I've got Alex Borneman, who has a bachelor's in business management with some financial background, and Zach Kaloritis, who is our financial consultant, who is a double major in business management and financial management. What we started to realize is that while we do limited services for our clients on that, on financial issues, we have an incredible capability to do this. And that is another thing that we have decided during this conference is that we are going to start offering financial services another option. I'm going to put Tony on the spot for a second here. Totally unexpected, Tony, but you can handle it. So, as we think about, and over the years, you and I have all, from our accounting days to our administrator days, we know the challenges that you meet as, to run the finances in an operation. And I think, all of the other things that we talked about are, obvious, like nursing, administration, life safety might not be so obvious. Hopefully we made it obvious to you now, but another area that we have to talk about is, ambulatory surgery centers are very different animals, and doing the financial management in a ASC is very different. So another thing that we are looking to do is to provide mentoring resources, again, to like a business office manager, or if it's the administrator, or heaven forbid, if it's the poor nurse manager, which does happen, where the nurse manager is responsible for financial operations. And you did that, in your time. How would that look? Have you thought a little bit about what that might look like? What types of services? Think about yourself. Going through what were the things that you had to teach your business people about?
Well, I don't want to take too long, but one thing I used to I don't know if you said lecture or instruct my nurses. Is that when we send out the bill, the bill is an abstract that represents what was done and what we're going to get paid for.
Yeah.
But if the Medicare or Blue Cross or another payer comes to look at the basis for that bill, they look at the medical record.
Very true.
The medical record is the real bill.
Yeah.
So the medical record, of course, is to take care of the patient, but it also is our record for getting payment for the services that are
proof that service was offered, right?
So, just to kind of tie the whole thing together, because it's so easy to, separate those functions of, you're doing this and there's a billion people over there, but they really need to work together.
Yeah.
So that's kind of a starting point for me to see how the whole thing works together. Then on that finance side, of course, you need it's an exacting measurement, just like, health care itself is an exacting science with some art. Mm-hmm. Well, accounting is an exacting science with some art as well. Right. In order to present your accounts receivable in a rational way so that the board can understand it, so you can know where you're at, and compare it to other healthcare, other ASCs to know where you stand. what your collection should be. And then just the financial presentations itself, how that makes sense to the board of directors, how that makes sense to you and to your management team, because it's important, I think, to bring in the lead managers, nurse leaders, as well as, key medical director or, key board members to understand those, how they relate. Then there's a whole matter of the costing.
Yeah.
Ann mentioned that before. I'm sure the nurses come up against that. It's a real irritation to you on one hand. On the other hand, it's a tremendous measurement, not only of the cost, but of, the resources you're using. Another problem when you come from hospitals, use of resources, So it really ties into the whole organization, but it's another language, the whole finance aspect that I think needs to have some understanding, fostered with us, and to take away the mystery of it. And to know what to look for. You're not going to, you're not going to be made into an accountant, but to understand how it really integrates in the whole thing. It's not just an irritation you have to put up with.
Right.
It really helps you to measure where the company is. So anyway.
Well, and I think this is kind of how we're going to end here, is just talking about how we've just described all of these things that you need to learn, that you need to be mentored on. Notice how all of them are interconnected. And Tony, you kind of just like circled right back to administrators and nurse managers, even nurse managers there, that as we're putting together these programs, by the way, as we're sitting here, it's like another light bulb went off, and Lori and everybody else here. It's just like, wait a minute, this is an interdisciplinary effort. As we put together these mentoring programs, you're going to have a primary person. If you're a nurse manager going through a mentoring program, you're going to have a nurse that's going to be your primary mentor. But boy, it wouldn't be a bad idea to spend some time with Tony. It wouldn't be a bad idea to spend some time with with our life safety people, and that can be said for everybody. Again, even a business manager better know how to talk to a nurse, better know how to talk to the administrator. And by the way, needs to spend a lot of time with life safety, because that's where all of your expenses are going to be. So I leave you all with this. First of all, I do want to, on behalf of the ASC Podcast, thank all of you for taking the time. You've had a lot of things to do in the last 2 days as we have been, sitting down and talking about the future of ambulatory healthcare strategies. I appreciate the fact that you're sharing with our audience those things that are of extreme importance right now in the industry and how you might go about it. And again, obviously ambulatory healthcare strategies is there to provide mentoring relationships. And if you just can't do that, if you're just out of time because, I'm looking at Lori, you're so busy batting away the alligators that are nipping at your feet, hopefully sterile alligators.
Depending on where I am.
Because you're in the operating room all the time, or because you are, you're spending time trying to, recruit new people. These are real life things. Then maybe it's time to think about outsourcing those services that can be outsourced. Ambulatory Healthcare Strategies is an organization that's there to be able to, we can write your minutes, we can run your board meetings, we can run your quality improvement meetings, write your policy manuals, do your educational programs. It's not a cheap option, and it's the type of service that you have when you really find that that's a more cost-effective way of doing those services. But I'm hoping you're all getting that the gist here, that there's free options, all the way from the ASC Podcast and shall we say, minor costs involved if you are a member of ASC Association or the state association, all the way up to, and a middle ground where you're getting mentoring, and then, the expensive option on that side. I will have to say our company has grown. AHS has grown dramatically within the last year and a half, because all of you out there are challenged with identifying leaders. You're challenged with finding staff. There's not enough time in the day. And of course, in many cases, your business is growing also because people want to have outpatient surgery. They don't want to go to a hospital. So please think about all the options we gave you. And thank you very much for your time.
So for the last past 4 years, we've really struggled to get up-to-date information on state association meetings, and especially now with things being virtual, and it's just, we don't find that it's been all that useful or beneficial for our listeners.
And so many people actually listen to the podcast well after some of these events occur.
I know.
So I'm not sure the timeliness is helpful.
Doesn't make sense. So we're just going to close out each episode in the future with a summary of what's coming up with the podcast and our virtual conferences, and we'll mention John's upcoming speaking engagements.
So we have 5 upcoming topics that we're going to have to get into within the next couple of weeks here. First is the discussion of the Surprise Billing Act. Next, an interview with Scott Megason regarding what to do when your coding or billing staff leaves suddenly. That's kind of a fascinating interview we did. We're going to do a focus segment on the ASC quality reporting and the changes in 2022. We're going to do a special interview with Amit Jarwani from SIS on data analytics and the future of data in the ASCs. And that sounds not so exciting, but it actually is very interesting because we talk about EMR systems and where we're heading in the future and how those things could be really beneficial. And then we're going to do our annual review of the OIG report on the compliance of accrediting organizations with the conditions for coverage during the surveys. And that's actually very important because it also, that particular report also gives us some advice or some indication of what are some of the major citations occurring in CMS surveys.
And some of our upcoming training programs. The Administrators Boot Camp is a virtual training program for new administrators and administrators that are preparing to take the CASC exam. The program includes weekly volunteer drop-in sessions with John and other staff from AHS, access to a large database of information, and a comprehensive 4-day virtual training program. The next live program is February 1st through the 4th, 2022, and there's also a self-paced version available at ascpodcast.com.
And the New Jersey Association January 26, 22 program is at Galloping Hill Country Club, and Ann Geyer will be speaking there, and I'll be there doing a podcast.
ASCA 2022 will be in Dallas, Texas, April 27th through the 30th, 2022, and John will be speaking in a special track for new ASC administrators. And go to ascassociation.org for more information.
And the New Jersey ASC Association Annual Conference is going to be June 7th and 8th at the Hilton East Brunswick, and I'll be speaking about succession planning. So I'm kind of excited to hear what I'm going to talk about.
And don't forget about our recorded events, all available on ascpodcast.com. Those include the Credentialing Conference, the Fall 2022 Finance and Accounting Conference, Conditions for Coverage Conference, and the Medical Director Conference.
Well, that's it for this episode of the ASC Podcast with John Goehle. And please spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Kelleritis, Amy Girbano, Lori Rodricks, and Ann Geyer. Music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, and Ambulatory Healthcare Strategies, the nation's leading regulatory compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast has been an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.